Okay, everyone, what we'll do is we'll start now. My name is Toby Richards, and I'm pleased to act as the chair for this presentation of the PostVenTT study. This study will be presented by the trainees and junior doctors from Australia and New Zealand. And if I could ask everyone to please turn off their cameras and also be on mute to ensure that there's no interference. We'll be moving to a full screen mode, and this is a University Teams webinar, so apologize if it's not to professional standards for everyone, as you may be expected. Now, the order of the day is as follows, and I'm moving to full screen. This project, the PostVenTT study, is the management of perioperative anemia in patients undergoing major abdominal surgery. It is a large study conducted by medical students and junior doctors through the Tasman and Strive networks across Australia and New Zealand. This study will be presented by a panel of the junior doctors and medical students. To start, Chris will present the background. Cameron will then explain how the study was designed against audit standards. And the methodology will be explained by Warren on how medical students and junior doctors came together as a large collaborative to achieve these results. The statistics will be explained by William, and that will lead into Jespo, who will present the results of the algorithms of care. Also in the results, we'll explain that the student perspective will be explained by Ken McPherson, and Laura will conclude before questions will be answered in the chat session afterwards. The presentation, as it will be, including me talking, is approximately 25 minutes. And we'd ask if anyone's got any questions either about the experience of running a large trial such as this, the knowledge gained, or the results of the data themselves. If they could communicate this via chat, we will ask the panel afterwards. Without further ado, I will hand over to Chris.
Hello everyone, my name is Chris Varghese and I'm a final year medical student from the University of Auckland, New Zealand, and it's very exciting to welcome everyone to the PostVenTT webinar, where we launched the first cohort study publication from the collaborative. It's my pleasure to begin the evening with discussions on why we chose anemia as a study topic and its importance in perioperative medicine. It's incredibly exciting to announce the publication of the first PostVenTT collaborative publication in the Medical Journal of Australia. The speakers tonight will outline the incredible student and trainee-led networks that delivered the study and its important findings. So why did we choose anemia? Anemia is highly prevalent, affecting over a third of patients preoperatively and the vast majority of patients postoperatively. There's also a large body of evidence demonstrating the detrimental impact of perioperative anemia on postoperative outcomes. These include increased postoperative complications, prolonged length of stay, poorer quality of life, and delayed postoperative recovery. This highlights the critical importance of managing anemia in the optimization of surgical care. Patient blood management guidelines, such as that up on the screen at the moment, give us the key evidence-based standards with which to audit our current practice. Next slide. There's a growing body of type 1 evidence accruing in this area, and it's an exciting time with regards to randomized trial. It has become recognized that anemia is a plausible treatment target for patient benefit. A recent multi-center randomized controlled trial, the PreVent study, suggests that preoperative IV iron did not impact on perioperative outcomes, including transfusion requirements or mortality. Notably, however, secondary endpoints suggested that recovery of postoperative anemia may also be a suitable treatment target, particularly in relation to readmissions, a finding which motivated the PostVenTT study. Next slide. Following the patient pathway with regards to intraoperative care, this is an incredibly exciting time with respect to the use of tranexamic acid, with the publication of the POISE-3 randomized controlled trial. This trial robustly demonstrates the efficacy of TXA in reducing bleeding events. With these important findings now being published, and as implementation into practice occurs, it is prudent to assess the real-world use of TXA in high-quality prospective studies. Next slide. PostVent is the first such prospective cohort study to explore the development and impact of postoperative anemia in patient care and offers a valuable snapshot of current practice. Next slide. For those interested in a deeper dive into the evidence base behind these guidelines, I'd refer you to Roman et al.'s network meta-analysis and systematic review, which comprehensively summarizes the evidence behind a whole suite of PBM interventions. I'd now like to pass on to Cameron Wells, who will talk about how we measured these audit standards. Thank you very much.
Cool, thanks Chris. My name's Cam. I'm a surgical registrar from Middlemore Hospital in Auckland, New Zealand. And I'll be explaining both how we chose the audit standards that we investigated as part of the PostVent study, and also explaining how we measured and assessed adherence to those. So to look at the prevalence, investigation and management of perioperative anemia in patients having abdominal surgery in Australia and Aotearoa, New Zealand, we used 5 audit standards that were adapted from the Australian National Blood Authority guidelines and from an international consensus statement that was recently published in the journal Anesthesia. I'll walk through each of these one by one and explain how we measured the outcomes that were assessed as part of the study. Next slide. The first audit standard we looked at related to the identification, evaluation and management of preoperative anemia. So this essentially was assessed using a composite endpoint, and amongst patients having surgery in this cohort, they were allocated to be either compliant or not compliant. So a flow diagram will step through on the right how patients were allocated to each of these groups. If patients didn't have a hemoglobin checked preoperatively, they were deemed to not be compliant. Of those that did have a hemoglobin checked and were not anemic, they were compliant with this audit standard. Of those that did have anemia, we then assessed whether they had iron studies performed, and if iron studies were not performed, they were deemed to not be compliant. Of those with iron studies, they were then classified as either iron deficient with a ferritin of less than 100 or not. Patients without iron deficiency anemia were classified as compliant, and then of those with identified iron deficiency anemia preoperatively, we classified those that did receive intravenous iron as compliant with the endpoint, and those who didn't receive intravenous iron were not compliant. We then used this overall measure to assess adherence with the guideline and its effect on outcomes, something that we'll touch on later. Next slide. The second standard related to the use of tranexamic acid, which is particularly interesting given the publication of the POISE-3 study since the PostVent study ran. So now there would be a case to recommend tranexamic acid in all cases of major abdominal surgery. However, to validate the findings of the POISE-3 study and to look at the current use in Australia and Aotearoa, New Zealand, we looked at the use of tranexamic acid intraoperatively, both in patients overall, but also in those who received an intraoperative blood transfusion, a marker of active major bleeding during surgery. Next slide. The third standard was a post-operative one and related to the use of restrictive transfusion protocols for post-operative blood transfusions. So this audit standard was assessed amongst patients who had post-operative blood transfusions, and compliance with this standard was deemed as a pre-transfusion hemoglobin of less than 70 grams per litre or 80 grams per litre in patients with pre-existing cardiac disease. Next slide. The fourth audit standard, also post-operative, related to the measurement of hemoglobin levels after surgery. We assessed compliance with the standard and it was defined as all patients who had a hemoglobin level that was measured at any time following surgery prior to discharge. Next slide. The fifth and final audit standard related to the use of oral iron for postoperative anemia. The guidelines recommend that oral iron is not effective for managing postoperative anemia and that patients with this should not be prescribed oral iron therapy. So compliance with this audit standard was patients who did have documented postoperative anemia that were discharged from hospital without a prescription for iron in an oral form. I'll now hand over to Warren to further explain the collaborative model that was used for this study and how it was used to deliver this study in particular, as well as its advantages overall.
Thank you, Cam. My name is Warren. I'm the intern working at the Royal Adelaide Hospital, and I will now explain our collaboration model. Now, the basis of our collaborative framework starts off with mini teams consisting of students and junior doctors, often with minimal research experience. These mini teams of 3 to 4 students are mainly responsible for data collection and face-to-face interactions with patients, supervised by hospital leads that have more experience in such collaborative projects. Next, regional leads coordinate with mini teams across hospitals, organize local ethics and governance within their region. Governing all of this is a group of senior researchers and clinicians within the steering committee and advisory group that provide oversight and organization into high level, i.e., ensuring the quality of the methodology. Now, the beauty of this collaborative model is in its open access framework. The key work on the ground is all performed by junior doctors and students. The steering and advisory committee provides the quality of an international standard. And what this means is that a medical student can be an active and important participant, learning more about the subject matter, more about how trials are run with international standard and quality, where results are likely to be published in high-impact journals with meaningful input. This platform provides a structure for leadership and teaching, one that allows people to be trained in skill sets crucial in leadership for future setup of clinical trials. Next slide, please. So how does this model work? As an example, together with Law, my role within the steering committee was in communications. We were responsible for the newsletter, non-traditional strategies of outreach such as utilizing Twitter, WhatsApp groups and social media communication to ensure everyone starts their data collection on time, chasing missing data to ensure the robust quality and completion of our data. Now, we did all of this by communicating between individual student and trainee groups within Australia and New Zealand, as seen on the right, such as Tasman, Hunter, Strive, Western Australia, and Start in South Australia, bringing everyone together as one. In total, we set this study up across 56 hospitals within Australia and New Zealand and utilized over 600 trainees and medical students, of which 1/3 were medical students. Now, to put this into perspective, the ANSCA Clinical Trial Network is only 70 hospitals. So our student and trainee network is one of the largest networks of research in Australia and New Zealand. And truly, the setup of this study is a testament in our strength and collaboration. I'll now hand over the time to William Zhu, who will now share more about our methods. Thank you.
Kia ora, I'm William Zhu. I'm currently a final year medical student in Auckland, New Zealand. So in terms of what we did, we registered the trial prospectively on the Australia-New Zealand Clinical Trials Registry and also sought national and local ethics approvals before the commencement of the study. Next slide, please. In terms of inclusion criteria, we included consecutive adult patients undergoing major abdominal surgery, and this was from a wide range of specialties, ranging from colorectal gynecology through to urology and abdominal vascular procedures as well. Next slide. In terms of technical definitions, we defined anemia as less than 130 grams per litre in men and less than 120 in non-pregnant women. And our primary outcomes were the compliance with audit standards as previously mentioned. And as a refresher, these included compliance with investigation of preoperative anemia, tranexamic acid use, a restrictive transfusion protocol, post-op hemoglobin investigations, and avoidance of oral iron. Our secondary outcomes included the number of transfusions required for each patient, length of stay and readmissions, as well as clinical Clavin-Dindo complications. The study also prospectively assessed clinical frailty score preoperatively as well as 30-day post-operatively to assess any changes. And anemia prevalence was assessed from preoperative times through to 30 days post-operative. Next slide. In terms of statistical analysis, our main concern was to compare the effect of compliance with an audit standard and non-compliance with an audit standard. And between these two pairwise groups, we compared categorical variables with a chi-squared test and continuous variables with either a t-test or Kruskal-Wallis test. And this was to see if there was statistically significant differences between the two groups. We also adjusted for the impact of age, sex, ethnicity, operative specialty and operative urgency to look at outcomes such as complication rates, length of stay and readmission. Next slide. This study emphasised greater than 95% data completeness from the start of the protocol through to the end of the study, and over 95% was achieved. This meant that our low missing data rates and high accuracy increased the confidence of our results and minimised the impact of missing data on any findings. We also completed a sensitivity analysis excluding cholecystectomies, as these are often completed as a day case, even though they are classified as major abdominal surgery. And as you'll see, this did not significantly affect the findings of the study. And now I'd like to hand over to Jessfo, who will talk about the results.
Thank you, William. So within 4 weeks, we recruited almost 3 patients across 56 hospitals. 25% of them underwent non-elective surgeries. Median length of stay was 3 days, and the proportions of specialties included in the study provided a good snapshot of major abdominal surgery in Australia and New Zealand. Next slide. Hemoglobin levels prior to surgery were checked in over 90% of patients. Iron studies were performed in a third of patients with pre-op anemia, and a third of those with iron deficiency anemia received intravenous iron. So overall, we did well with pre-op assessment and management of anemia being achieved in about 3/4 of patients. Next slide. Next slide. Why does it matter? In our multivariate analysis, adherence with guidelines was associated with lower likelihood of red blood cell transfusion and also post-op complications. Next slide. Tranexamic acid was rarely used in Australia and New Zealand. It was most frequently used in gynecological patients and those with severe anemia with a hemoglobin pre-op less than 80 gram per litre. Interestingly, in our sub-analysis, among patients receiving intraoperative blood transfusion, only 1/4 of them actually received tranexamic acid. So perhaps this is an area that we can do better in the future. Next slide. In total, 167 patients received transfusion perioperatively. Adherence with guidelines were achieved in 96 patients, which is 58%. Restrictive transfusion was not associated with any adverse outcomes. Next slide. This is a Sankey plot showing how patient hemoglobin changed during the course of their admission. The red portion represents patients with anemia, whose proportion increased significantly throughout the admission. What's important is that anemia remains a big problem on discharge, with almost half of patients undergoing major abdominal surgery left hospital with anemia. And why is it important? We found that anemia at discharge were associated with almost double the rate of 30-day readmission. We think this is an important take-home message and a finding that requires further investigation and action. Next, Ken will be sharing with us his experience being part of the study.
Thank you, Jess. Hi, everyone. My name is Ken McPherson, and I'm a final year medical student at the University of Western Australia. And last year I worked on the PostVent study at Fiona Stanley Hospital. And as Warren spoke about earlier, in the collaborative research model, data collection is performed within the mini teams. And I personally collected data on patients undergoing major abdominal surgery within the specialties of vascular and transplant surgery, along with covering in the acute surgical unit. For the recruitment period of the study, I met with patients on the day of their procedure, preoperatively where possible, and recruited them to the study. This involved explaining my role and taking a history from the patient surrounding their clinical frailty and preoperative management. I then met with them in the post-operative period and then called them at 30 days post-discharge to see how they've gotten on at home, specifically asking whether they had been readmitted to hospital or taken oral iron, along with assessing their frailty. The rest of the data collection was primarily records-based and involved going through the patient op report, anaesthetic record, clinical notes, discharge summaries, and their lab results. As a medical student volunteering to be part of this study, I benefit in many ways. And firstly, the research experience I gained from it. So I had minimal experience in clinical research going into the study. I'd learned about research methodology as part of my course, learning about randomized control trials and systematic reviews. However, what you fail to learn from this teaching is how research looks in a clinical environment. The collaborative research model allows for students learning to not just stop at data collection as well, but as they gain experience in participating in these studies, they're encouraged to take on more responsibility and climb the collaborative research ladder for subsequent studies. As a result of this, students are exposed to and supported through local ethics and governance, again, another skill that is not typically taught. The end result is a junior doctor well-versed in clinical research skills and capable of readily engaging and initiating research into the future. Talking on my own experience, I feel that as an intern next year, I'd feel comfortable approaching a consultant to engage in research, knowing that they wouldn't have to hold my hand along the way. Next slide, please. So secondly, the clinical experience. I found that participating in the study goes well beyond research experience. I'd almost consider an adjunct to students' regular clinical placements. Students follow patients' perioperative journey closely, comparable to performing multiple small case studies in order for them to complete the data set required. In addition to this, students need to build rapport and develop their clinical communication skills with many interactions with patients, both in person and over the phone. For me, it meant learning about the immunosuppressants in transplant patients, as well as getting to go on call with the transplant team to scrub in for theatre. Having had my great experience, I have done and will continue to highly recommend collaborative research to medical students. I'll now hand over to Laura, who will conclude and discuss the future of research in this area. Thanks.
Thank you, Kenny. I'm Laura. I'm a final year medical student at the University of Adelaide. And I'll be presenting the conclusions of this study. The PostVent study is the first Australasian-born student and trainee-led collaborative study. It is also the largest prospective audit of postoperative anemia internationally. With a total of 2,730 patients recruited across 56 hospitals, we were able to achieve an impressive 98% data completeness rate and outline perioperative variations in anemia in patients undergoing major abdominal surgery. Next slide, please. So to conclude, the PostVent study has allowed us to demonstrate that the student and trainee-led collaborative model works and provide robust, high-impact results. We were able to show that anemia was a significant problem in surgical patients, and we were also able to identify several areas of improvement in our adherence to the PBM guidelines, particularly pertaining to our use of tranexamic acid, where substantial blood loss is anticipated. And in terms of future directions, postoperative anemia has been shown to have an impact on outcome and particularly readmissions rate, and could be an attractive future interventional target for future research. Thank you. We'll open up the floor for questions.
Right, thank you very much to the team. We have plenty of people on the call, and the panel is now open for any questions. If I could ask you, if you have a question, could you please post that in the chat, and we'll address the panel as a whole, or if you have someone specifically that you want to answer, please let us know. But perhaps I could start and say to Cam and perhaps other members of the panel, what do you think the message is from this study that you've learned?
Yeah, thanks, Toby. I think for me, the main takeaway from this that I've come to after reflecting on the study for quite a while now is that perioperative anemia is probably a lot more common than most of us realize in day-to-day practice. I think we discharge people quite commonly with hemoglobins of 90, 100, 110, and don't think too much of it. And this study has really highlighted for me that both preoperatively, but also even more postoperatively, there are a huge proportion of our patients that are anemic. And often we don't do a very good job of recognizing or managing that. So for me, it's really been an eye-opener for how common perioperative anemia is, and being a bit more mindful of managing that in the perioperative setting. So I've now tried to actually look at these people's hemoglobin postoperatively, and if they do have a hemoglobin of 100, think about whether they'd benefit from iron or not, or if there's anything else we need to do, particularly given that association with readmission. If there's something that we can do to stop them coming back, that's really important. And that's obviously an area for future research as well. But it's something that I've been much more, I guess, aware of in my day-to-day practice after this study.
Thank you. Chris, any comments from this study?
I think one of the key takeaways for me was seeing the use of tranexamic acid in the real world practice. We've all kind of had lots of discussions with general surgical colleagues in particular about the use of tranexamic acid intraoperatively, and I think there's a fair bit of equipoise in the years before around its efficacy and its role, particularly outside of gynecological surgery. And now with the publication of the POISE-3 trial, we've got some definitive answers about the patient benefit that can arise with its use. And the PostVenTT study provides us an answer of how commonly it's currently being used, and 4.7% gives us a lot of room for improvement, and a lot of potential patient benefit we can derive from this. So there's a lot of sections in this manuscript that we can tease out to improve practice based on the best available literature.
And I'm going to ask the other medical students, Ken and Warren and Laura, from your participation in this study and also seeing the results, what are your sort of personal comments? And maybe I can start with Laura if you go first. Sorry to put you on the spot.
Yeah, I think taking it from a very different perspective, looking more at the structure and methodology of this study. This is the first Australasian born collaborative model, and I think we've learned a lot from the experience in the UK, and I think this demonstrates that we were able to successfully implement it here, and there's a lot of strength in the collaborative model that we were able to build, as well as the strong connections we have between the different networks across Australasia, Tasman, Hunter New England, Strive WA, Stark SA. So I think from a methodology point of view, there's also a lot to learn in terms of future studies and expanding into other models of research as well, or other than audits as well. So yeah.
I think, hi everyone, I'm Warren. I think my take-home learning point is twofold. One of them is clinical. As Cam rightfully mentioned, just to be more aware, for instance, during pre-admission clinics, when patients come in, for elective surgery, it's important to check the patient's anemia status, and more importantly, their iron deficiency status as well. But beyond just clinical work, I think also, because Laura and our main focus is on communications. I think in future projects, we want to get medical students more involved. As mentioned, only 1/3 of medical students were involved. One out of the 600 collaborators involved, 1/3 were medical students. And I always feel that there's no such thing as more than enough medical students, and we can always beef up the number of students. But beyond just data collection, I think their role can be utilized more in, for instance, writing the manuscript, or presenting more of these such webinars or abstracts in future conferences. So these are my two take-home messages.
Thanks very much, Ken.
I think for me, it's more of a ground level thing that I found. I'm not sure many people got much exposure to, was the benefit that came with piloting the study. We ran the pilot out of Fiona Stanley, and being able to do that not only allowed the students who were going to be collecting data to work out logistical things such as rosters, where to find the data, and things like that. But in terms of doing it before the complete protocol was completed, we're able to really finalize and structure the REDCap so we can collect the best data and we don't miss anything important, or even work out if some things aren't practical to be able to collect given the data that's already collected in the hospital setting. I think there was a lot of benefits that we were able to add to the REDCap and the protocol before releasing it to all of the sites by piloting it.
I think that's a very important point, Ken, and it's something that Jonathan has just raised on the chat, which is, what would you do differently next time? And the use of multiple pilots is incredibly important. Never underestimate how difficult it is to collect good quality data, even though it seems simple. One of the things that he's raised, people have talked about what you've learned. What have you've got another project running on at the moment, I think. Is it Chris, are you head of Tasman at the moment, or were you involved? What have you done differently on this year's project?
I think all the heads of Tasman are on the call, so we can all comment on that. I think one of the keys with running the multi-centre studies, particularly in Australia and New Zealand, is getting started early, because we've got incredible heterogeneity in terms of the ethics processes and local administrative burden that's required. So planning ahead and really having a robust protocol available ahead of time to give lots of people time to join the study really maximizes the number of centres, the number of collaborators, and therefore the number of patients involved. So organisation's definitely key. And PostVent was a really good learning experience from that. And we took that on board starting several months earlier with operas from a Tasman point of view.
Admittedly, most people on the call are junior doctors, but one of the other questions is, now as medical students or as junior doctors, what are you going to do about perioperative anemia moving forwards? And this is more of an opinion than something reflected in the data. Maybe we should start with Jess, because you are one of the preset trainees who works in the field of vascular surgery, so you're very used to anemia.
Thanks, Prof. So I think especially in non-emergency surgeries, I'll be more aware of checking pre-op anemia and actively managed preoperative anemia, and in terms of intraoperative, it's interesting to find out that tranexamic acid was rarely used, despite the good evidence behind the use of tranexamic, and also the fact that patient blood management has been implemented and promoted for almost a decade in Australia, and to find out about the use of tranexamic acid in less than 5%, that's quite interesting. So I think that is something that we can do better in terms of better perioperative anemia management. And also, I think as being a collaborator in this study, I also been more aware of the impact of anemia on patients' complication when they left the hospital, and the fact that a lot of patients left the hospital with anemia but wasn't followed up properly, and a good communication with GP from that point potentially will be one of the key management moving forward.
Great, thanks very much. Some questions have come up about the variation in ethics and governance, and this, for those that may not be aware, is something that's been addressed at a state level and i.e. federal level. There is incredible variation and heterogeneity in the definitions of audit and research. This is essentially an audit. There is no research here. We have simply, the team has assessed what is currently going on in hospitals around Australia and New Zealand, and whether or not what we currently practice is in line with current guidelines, i.e., are we doing what we should be doing? There's no research here, there's no new data. And therefore, in many countries around the world, this simply would go through a local audit process and not require ethics and governance. And that was incredibly heterogeneous throughout Australia and New Zealand. And it took the team here, supported by a trial manager, Juliana and Doug, 6 months to set up all the approvals for this study. So in terms of investment, there's a best part of a year's salary in the background to this, not including the vast amount of effort put in by many people such as Jess and Cam and Ken and Laura, Warren, etc. on this call as well. So the overheads are significant to do something like this in terms of personal and financial investment. What can be done to make this better in the future? My view is, you've heard it from Ken, is that if you can train 600 junior doctors and medical students in quality of research such that they enjoy it and get something rewarding out of it, as opposed to a not so good project that you don't get something out of, you will build the profile and enjoyment of research moving forwards. That's my opinion, but I'll hand that over to perhaps some of the medical students for their opinion. Maybe Warren, did you enjoy this? Do you think it's worthwhile?
Yeah, definitely. We started this project last year when I was a final year medical student. My role again in communications, really enjoyed liaising with all these hospitals and all these students and junior doctors. Gave me a good opportunity to work on also very non-tangible skills, such as learning people skills, learning how to talk to people, how to motivate people. And I think that's the main things I've learned. Moving forward, now that this paper is published, as an intern at the RA, I will carry forward the results and the conclusion of what I've learned. So, for instance, preoperative anemia during pre-admissions is also very important, something that I'll look out for, and sort of tracking the journey of anemia throughout a patient's post-operative recovery as well, and also just to keep with caution whenever me or my team discharge someone with anemia post-operatively.
Thanks
I could potentially add a little comment on that from an ethics perspective. I think Warren and I have helped with PostVent, but also operas in South Australia. And from one project to the next, we've seen those barriers reduce as the system gets more familiar with this model, with students submitting ethics processes. So from that perspective, it's not only good to learn those processes, but also see those barriers getting easier with time. So that's also quite promising.
Well, thanks very much to everyone on the call. Unless anyone's got any, does anyone on the panel have any further questions or words of wisdoms they would like to impart? In which case, I'll say thank you very much and can only applaud the amount and quality of work that's been undertaken by everyone who's presented here today. I think it's a huge success, and that is obvious by the fact that this is being featured in the Medical Journal of Australia. So everyone now has a collaborative authorship on an impact factor 4-star journal of about 12 to 13, which is fantastic. So very well done. And we'll close unless there's any further questions there. And thank you very much for attending. The webinar will be available online and we will post that through social media. Well, I won't, Laura and Warren will. Bye for now. Thanks, everyone.